Delighted that Dr. Igor has permitted me to interview him on a subject that is very close to my heart, and I think in this day and age is incredibly close to a number of people's hearts. So let me just give you an introduction to Dr. Galynker's background. He is a professor of psychiatry at the Icahn School of Medicine at Mount Sinai, also a director of suicide prevention research lab at Zirinsky Center for Bipolar Disorder. But today, if you're okay with this, Dr. Igor, to concentrate on a new diagnostic model that you are putting together with the DSM of suicide crisis syndrome. We've got a relatively short interview for such a profoundly intense subject, but I am just so pleased that you've agreed to do this. So first of all, I'd like to say welcome and thank you.
Well, thank you for having me. It's a pleasure, and I really appreciate the opportunity.
Yeah, and I think, Dr. Igor, you do your work and you're in the thick of the work, you know, the whole of the mental health world when you're a psychiatrist. And just to explain to people, psychiatry is different to psychotherapy. So I'm a psychotherapist. I know lots of psychiatrists who also are psychotherapists. So I deal with the talking cure. Can you just give a brief overview of what you do when you work in your day-to-day position?
I do a lot of things, and one of them, actually, I do a lot of therapy myself. My identity is primarily a psychotherapist, but also psychopharmacologist, a researcher, educator. I do a lot of things, including therapy.
Amazing. And I think that has been where a lot of psychiatrists are going. Now, people often say to me, can I give people medication? I can't, but you can.
Yes, I can, and I do.
And you do. And of course, you have to. And this is the misnomer that people have about the world of mental health. It's so vast, and there are people who do different styles. Lots of people call themselves therapists. Because over here, and I'm not sure how it is out there in America, but over here, there is no body that regulates. You are regulated, of course, but you don't have people overseeing and saying, no, you can't call yourself a therapist. So lots of people call themselves therapists, which is not a good thing, but you are profoundly in the thick of the work you do. Can I jump straight into, because we're limited for time, into a new diagnostic that you have put together with the DSM? For those who don't know what the DSM is, it's a diagnostic statistical manual for mental health, mental disorders. And it's something that more and more people are turning to. Now, this is the 5th edition. Are you going into the 6th edition?
Correct.
Yeah. So it's very interesting because it's an American-based concept, isn't it, the DSM? But
DSM is, but there is a world equivalent of it, which is called ICD. And I'm working with ICD committee also.
Excellent. And I must say, had it not been for you, you have touched on something with suicide crisis syndrome that I have dealt with people, particularly a number of people during COVID, but before that. I was a Samaritan, I don't know if you know the charity over here in the UK, when I was 18, 19. So I dealt with a lot of people that had the suicide ideation, you know, sort of on the edge psychologically. But you have created a model to help people understand exactly the difference between suicide ideation and this particular model. Now, lots of people are trained about suicide ideation, that you should ask somebody, are they suicidal? If so, how, and what are the images that they have? But can you go into the difference between the suicidal ideation and your suicide crisis syndrome model?
Of course. So, the reason I'm doing this, meaning this research, and I've been doing it for 17 years, is that I'm very actively practicing clinician, and I assessed by now probably 30,000 people, 10,000 of them suicidal, and 3 people died in my practice by suicide. over 30 years, and then 9 died within a month after they left my practice for one reason or another. What I remember them all very well, and what they have in common, all of them, nobody told me that they were suicidal.
Yeah.
Okay, although I asked. And this is I'm doing why I'm doing what I'm doing, because if you step back and try to think out of the box, suicidal mental state is the most lethal psychiatric condition, because people die in suicidal mental state. People with schizophrenia die in that state. People with depression die in that state. Everybody dies. So it's the most dangerous psychiatric condition. And yet, until very recently, there was no diagnostic description of it, as it would be for depression, schizophrenia, panic attacks, or any other disorder. Instead of that, we rely on asking people who are in the worst moment of their life, if we're talking about people being truly suicidal or in danger of ending their lives, let's rephrase that, to tell you accurately what they're planning to do, and you rely on that as the centerpiece of your diagnosis and suicide prevention. Do we ever ask people with schizophrenia to diagnose their schizophrenia and rely on their diagnosis? Or people with bipolar disorder to diagnose mania and rely on their diagnosis? And yet we have this condition which is more dangerous than both of those, and that's what we do. So that's why. And the difference is to apply a medical model, okay, to what is a mental illness with a potential lethal outcome if people do die by suicide, and describe it objectively, diagnostically, so people can objectively and diagnostically assess it without relying on people telling you truthfully what they plan and do not plan to do, because they don't know. Or if they do know, they may hide it. But a lot of the time, they just don't know themselves at the time that you ask. But the condition, meaning the suicide crisis syndrome, is there. It's already there. They just don't know what is going to happen and how.
So in the model you're creating, I've looked at the model, and there are areas of their mental state that you would be asking them about. Is it in a dialogue that you'll be ascertaining the model? You'll be using the model. It's in a actual dialogue that you'll be finding out what their state is, as opposed to a written state. Because a lot of work is done written over here, you know, sort of for things like ADHD and everything. People have to write everything out, as opposed to a sort of with a therapist.
Well, first, I will have to ask if they're in my office. Most of the time, however, people tell you. You just need to listen. Like people tell you that they're depressed. People tell you that they're anxious. In the same way, they can tell you whether they do or do not have the syndrome. You just need to know the criteria so you can recognize it. And then you can ask more questions and make the diagnosis. Usually when people come to your office, they tell you what it is, and it is, I'm stuck. Okay, stuck is trapped. This is criterion A for the suicide crisis syndrome. Okay, and or I just broke up with my girlfriend, and I can't see the future without her. Okay, which is also a syndrome, and then you ask questions about the syndrome. So you listen, just like all psychiatrists and therapists and regular people should do, and then you have a conversation, and then you make a diagnosis.
And
it is not an interrogation, by the way. That does not work.
No, quite. It's got to be a conversation, because basically that's therapy, isn't it? People won't open up if you're interrogating.
Yes, of course.
You know, and that's what you do. That's how you've come to this point. That's why you've been dealing with so many people. Before we go further into the sort of diagnostic areas, in all your work with all the people that you've dealt with, have they all shown, I presume they've all shown these are the areas that created this model? Or have they shown one specific area that is highlighted to another?
Uh, the people are different, and people can have incomplete syndrome, let's say 4 out of 5 criteria, or they can you can have one, and it's you see, the thing is, the syndrome is short-lived. It's like a wave.
Mm.
Okay, it comes over you, and I would say probably on average it lasts maybe a day or two. It responds very readily to treatment if you if you treat with the right medications. Yeah, people can have various combinations of it. For instance, one of the criteria is that people are evasive talking about it, and or they kind of withdraw from other people, and that those who have incomplete syndrome, for instance, can still not sleep and be stuck and lose the ability to think, but they can share it with somebody. I mean, it's also possible. If they do, then the syndrome is incomplete and the danger is less.
So just to go through the model, we've talked about entrapment, I'm stuck.
Also, let me qualify the two different concepts.
Yeah.
So suicide crisis syndrome is a diagnosis. That's what we're talking about. There's also a model, which is narrative crisis model of suicide, which is staging of suicidal mental process that goes through stages. It's a more recent development, but also intuitive and useful. So what I'm gonna go over right now is the criteria for the suicide crisis syndrome. Okay, and if we have time, we can go through staging also, because it's important. So the suicide crisis syndrome has 5 criteria, 1 criterion A and 4 criteria B, and all criterion needs to be met for the syndrome to be diagnosed. In adults, criterion A carries about 50% of the weight. It's the most important one, but not in adolescents. I'm going to come back to that. So criterion A is the feeling trapped in unbearable life situation that you want to escape because it's unbearable and all routes to escape are blocked. So death appears as the only option. Okay, that's the criterion A. It's really, really important, because if people see options, then the danger much, much less. Okay, maybe no danger, I would say. The second criteria, B1, is affective disturbance, and it's emotional pain or severe anxiety with sensations you never experienced before, because SCS, or suicide crisis syndrome, is primarily anxiety and panic state. It's not depressive state. And inability to experience pleasure and emotional turmoil. These are the parts of criteria B1. And the way to talk about it or listen for it is like that. So if you're a therapist, somebody is in your office, the question is, and they tell you about their problem. Okay, and the first question is, so the problem that you're telling me, do you see a solution to it? Is there a way out? Okay, and if people say, there's no way. I mean, whatever it may be, financial loss is catastrophic. Woman of my dreams left me. My children don't speak to me. There's no way out. Okay. Then criteria A is met. Okay. So the next question that you ask is about criteria B1. So when you this condition that you're in, the story that you're telling me, okay, is it painful to you? When you think about it, I mean, do you feel emotional pain, or does it make you anxious? I mean, do you feel anything strange? I mean, is it that bad that you feel anything strange? So That's criterion B1.
Mm-hmm.
Criteria B2 is loss of cognitive control. And it means that people feel they cannot control their thoughts, that go into a rabbit hole of negative thinking about the problem that they came to see you with, and these thoughts are just keep circling and circling, and it's so bad that it gives you headache or pressure in your head, and sometimes people feel like their head can explode. And they cannot suppress those thoughts, and they cannot deviate from those thoughts. No alternative. And the way to ask about it is that when you think about this problem, can you control your thoughts, or you feel your thoughts are controlling you? Okay. And so criteria B3 is over-arousal, and it's a combination of several things. It's insomnia, and it's hypervigilance, being hyperattentive to other stimuli, irritability, and agitation. And the way to ask about that the easiest way. So when you're in this situation that gives you emotional pain and you cannot control your thoughts, can you sleep? Or does it happen at night and you can't sleep? That's the easiest way to ask about it. And people tell you, no, I stay up all night. Can't do it. And finally, the last criterion is evasive communication with others, or acute social withdrawal. People stop talking to their friends. And the way to ask about that is, have you talked to anyone about this? Does anybody know? And who knows? And what's the last time? And and the person said, no, nobody knows. I cannot tell them for whatever reason. That's criteria B4. So that's the syndrome. And if somebody tells you that the woman of my dreams that I met and I stayed with for a year, the only one for me, left me yesterday, and nobody else will do. Nobody. No possible. No other women exist for me except for her. And my pain of losing her is unbearable. And I can't stop thinking about this and everything that I've done wrong, or that I could possibly have done wrong, that cannot be corrected. And this gives me chills and I'm shaking. And I cannot sleep at night because that's all I think about. And I cannot tell anybody because I'm so humiliated and it's just so terrible. Okay, this is the syndrome. And whether they tell you after that, no, I'm not going to kill myself because I'm thinking about my mother, okay, you will take that with a grain of salt. Suicidal ideation may or may not be present, and it's unreliable.
And you said there was another series of aspects of your client that you should be looking at.
Yes. So the suicide crisis syndrome, it's the most acute stage of suicidal mental process that is associated with imminent risk. It's an illness. Suicide is not an illness. Like mental state, SCS is an illness. So it develops fairly predictably in time. The model that describes that development is called narrative crisis model. We also published about it. It has 4 stages. So the first stage is when somebody has long-term risk factors for life, for suicide lifetime. And there are several of those that increase the risk lifetime, not immediately. And like perfectionism is one of those. Fearlessness is one of those. Lack of moral objection to suicide is one of those. And so people are like that. They're at higher risk for suicide over their lifetime than people who are not like that. Okay. But if nothing is happening, this is just, their personalities, and there's no danger. So that's
do you also look at, because I've had clients who've had suicides in the family, are they more likely?
That's part of it. That's part of it, yes.
Yeah.
There's many factors that increase your risk suicide over your lifetime 2-3-fold. And all these are these factors that do that. But again, if nothing, there's no immediate danger. You don't need to worry about it.
No, not immediately, unless they have a crisis.
Right. So then stage 2
okay,
is the crisis.
Mm.
meaning that something happens, which is a stressful life event or a crisis that usually come in about 5, 6, 7 varieties,
Mhm. Mhm.
really. And one of them is final romantic rejection.
Yeah.
Another one is catastrophic financial failure. The
Yes.
third one is onset of life-threatening medical illness.
Yes.
Another one is a threat to ego identity,
Mm.
like losing a career or a job or something like that, that your basically identity, or a mother becoming like a terrible mother, children not talking to her, something like that, or losing the children. Bullying,
Yes.
and relentless mental illness that does not respond to anything that's painful.
Mm.
Okay, which is the hardest of them all, actually,
Mm.
to treat. So when the goal is to be normal. So when people with stage 1 have this crisis, stage 2, okay, and they continue to behave the way normally do, there's still no danger.
Mm.
However, if some of them will go into stage 3, okay, at stage 3 we call suicidal narrative.
Mhm.
And it's a narrative identity of their perception of themselves. It's a kind of cognitive state, how they see their life. And they see their life in the following way. Generally, it's the same story. I had a goal that I was striving for all my life. Okay, and I'm falling short, or I fell short. I'm not going to reach it. And I cannot disengage and accept another goal, which is a lesser goal.
Mm.
I cannot, there's no other women.
Mm.
If I wanted to be a doctor, I cannot be a nurse. If I wanted to be a ballet dancer, I cannot be a dance teacher.
Mm. Mm.
They cannot disengage, and they keep pursuing it, and it becoming more and more desperate because they're not going to get there.
Mm.
And that results in a feeling of profound humiliation and defeat,
Mhm.
that sometimes public, sometimes not, but usually public. And with that, they cannot turn to anyone because they're so embarrassed,
Mm.
okay,
And
and
a shame.
ashamed.
Yeah.
They feel like they're a burden. They feel like they don't belong,
Mm.
and there is no alternative. There's
Mm.
no future. Okay, they cannot have an imaginable future. That's the story.
Mm.
That's a cognitive story called suicidal narrative.
Mhm. Mm.
That is associated with subacute risk,
Okay.
not immediate risk. Okay, but here where risk appears, because people like that, with something else happening, possibly a second trigger, go into a crisis, which is imminent risk.
Mm.
Risk that I describe, it means you can't wait. You need to do something now. You need to intervene. So our goal is narrative is longer.
Mm.
It lasts weeks, and it is better if you can to intervene at the narrative stage.
Mm.
Okay, before people develop a crisis.
Mhm.
And the important part of this model is that there are treatments specific to each stage. Because if somebody in a crisis, the treatment is medications. They cannot hear you. You
Mm.
cannot tell them there are other women. Okay, they just, it doesn't falls on deaf ears.
Mm.
You cannot tell them that, the possible other careers or something may happen. They can't hear you. However, if you treat them appropriately with the right medications, there's fairly quick response, usually. And that state subsides. The narrative stays still, because medication do not treat the narrative.
Mm.
Okay, but narrative then can be treated with psychotherapy and crisis intervention. Okay, because at that point in the stage of narrative, people can hear you.
And at that point, because we're dealing here, this is an interview that will be not just for therapists, but for many people that will be interested in what you're saying, and this diagnostic that you're giving and breaking it down so clearly is also for the ordinary public and family members.
Absolutely.
Who also, how do they cope with, if they have got this sort of suicide narrative? You can see it with a number of people that are in the public eyes, sort of big entertainers and so on, that find that their world has suddenly changed and something is going to expose them that is, as they see, shameful.
Mhm.
How do you suggest that they should be dealt with at that moment?
The important thing is that they need to be dealt with.
Yeah.
It cannot be ignored.
Mm.
It must, because at that point, the risk of suicide becomes foreseeable.
Mm.
Okay, it's not lifelong, it's actually on the radar.
Yeah.
And although they're not suicidal, they're not telling you that they're suicidal,
Mm.
even feeling suicidal, but the risk has increased. And the intervention is essential because even at that point, it's life-saving, although people are not suicidal.
Mm.
And intervention is just assessment, being in treatment, being with a good therapist, crisis intervention therapist. Medication may be helpful with that, but those will be different medications that are for crisis, because there's no urgency for them to work instantly
Mm.
as they are in crisis. You have time.
Mm.
Okay, but engagement and treatment is essential.
What about coming back to the family and the public? If it's in your family, and there's always this aspect of people who, at that moment of crisis, do take their lives when somebody goes out, so they're alone. How should
When
they?
somebody is in the moment of crisis,
Mm.
uh, uh, they they in my opinion, they're not going to do it if they don't have suicide crisis syndrome.
Yeah.
Crisis happens, stressful life events happen, and they don't have the syndrome, meaning they're thinking clearly, they're sleeping, they don't feel trapped, they're trying to ponder the situation. There's no danger.
Yeah.
The danger is when a narrative appears and that I failed and there's no future.
Mm. Mm.
Okay, then the danger appears. Then you need to interfere. And people may not be actively suicidal.
And how do you suggest that somebody does that if the person is not in under somebody like you, or even a therapist can't force somebody?
The most important thing, both with the narrative and in the crisis,
Mm.
is being able to imagine alternative future. It's cognitive restructuring. Okay, the life narrative that leads nowhere, life narrative needs to lead somewhere.
Mm. Mm.
Then people are not trapped. And so what you do is that you very intensively open doors for people and alternatives. And once they start seeing alternatives, then the danger recedes.
Subsides, yeah.
So yeah.
And how important, when I found you, you were doing another interview, and you did talk about the importance of a family.
Family is critical for prognosis. Now, clinically, I work in the Family Center for Bipolar Disorder. Okay. It uses a family approach. We don't take individual people, only take families. Patients must come with their families, identified patients. A lot of people, excuse me, a lot of people that we see are suicidal. Because we treat bipolar disorder, and there's bipolar depressions, which can be severe, and anxiety states, which can be severe. Most people are suicidal. And what we discovered, although it may be common sense, is that when you use a family approach and you have what we call the treatment partner in the room, it could be a mother, it could be a wife, and you talk about this, you become a team with the family.
Mm.
Okay, there is no protection. I mean, there's open communication, and the family sees what you're doing. Okay, and you see what the family is doing.
Mm.
You're on the same side. And that allows you almost like 360-degree vision, which is protective, like a protective bubble
Mm.
of family members. So because the person who may be suicidal, who's coming in, if like the worst case that I know is that somebody was suicidal, a man who was in the 30s and a mother who was in the 60s told me, not with the patient in the family, in the room, but told me, why, uh, why, why do you stop talking about it? You're talking about it so much, kill yourself already. Okay. So, and she says it to me, but she can say it to him in family. Okay. And that would could be the straw that actually breaks the camel's back. In this case, could be the
Mm,
family.
mm,
So you keep control of that with the family approach.
mm,
Okay? And also, if somebody does die by suicide, the family feels and knows that you, together with them, did everything possible,
mm.
that there's nobody to blame. Because, some people die by suicide no matter what,
Yeah.
because the condition could be unbearable and you could do absolutely everything, and yet it still may happen.
Mm.
But it's not other people's fault because somebody missed something. Nobody missed anything.
It's such an interesting approach, because over here, people are reluctant to involve families. But I do think that it's so important that people around understand your medical condition.
Of course. And I'm doing it, it's not only there, by the way, that families isolated from the patient because of the confidentiality laws.
Mm,
It's the same in the United States. I just think this is wrong.
mm,
This is wrong. This is actually harmful, because most of the time, particularly for adolescents, actually specifically, it all may start in the family and end in the family.
yeah.
By the way, in adolescence, I mentioned the entrapment is not the most important factor. It's social isolation, social withdrawal is the most important factor.
Social withdrawal, yes, that makes sense. And how does that, we haven't got a great deal of time, but talking about social withdrawal, how does that impact then, or is it a double impact on teenagers who are stuck in a room, do all their learning online and then play with friends online and do computer games, and the parents are not active or interactive with them?
This is terrible. This is a national and world tragedy that is, has become already explicitly clear, that resulted from social media and essentially iPhone and the changes in technology that created this terrible environment where parents are overprotective of children from very early on in like real life, and absolutely no protection whatsoever or understanding what's happening in the cyberspace, where most of the life is happening, with people are disembodied, and it's like wild west of the internet, where basically if a situation is life-threatening. And I can go on. It's a separate issue that we don't have time for.
No, but I was just wanted to touch on that, just so that people are aware that if a child, as you say, especially for an adolescence, if they are socially alienated, they are being alienated not only from the family by sitting in their room, and I know of people like this, but they're alienated through the university, because a lot of university work is done online, and
Yes.
also in their minds, and they don't have parents that interact, friends don't interact, universities don't interact, and the child, as you say, goes into cyberspace and they almost detach.
With no resilience.
With absolutely no resilience.
And that's
Isn't that a case for a lot of people? How do we make them resilient? But I must say, from my point of view, I've dealt with a number of people who've been suicidal, as I say, and it's been almost a lifelong quest to, and I continue with charities to help people with this. But just to say, from my point of view, how helpful this is and what you're doing, it's very helpful. And is there one thing in particular, what can you really look out for? Because families are so sort of separate from their children, and not just adult children. What do you look out for? What do you notice, first of all? Is it in the dialogue? Is it in their behavior?
The danger signs, you mean,
Yeah.
right? Okay. The danger signs. I would say you start from the end, meaning from stage 4, because this is where the danger is imminent. Okay. And in stage 4, it would be a feeling of being trapped, feeling like in pain. And the main thing is that people keep saying the same thing again and again, which is they lost the control with their thoughts, and you cannot make a dent in it. They keep thinking there's no logic, doesn't work. That's really a danger sign. And of course, if they're not sleeping and all that, and they're locked in their room, but probably the most two things is that one is there is a situation from which they feel totally devastated and they can't escape. That's unbearable. In two, they can't control their thoughts when they think about it. And you can see that because first they talk about it, and second, they can't stop talking about it.
And I presume drugs and alcohol exacerbate all of that.
Yes, absolutely.
So you've got all of those compounding into a very dark place for a number of people.
Yes.
Dr. Galynker, thank you so much for allowing me to interview you.
Well, thank you for interviewing.
And it's not only a pleasure, but an honor, because this work is incredibly important in this day and age. And it will help people identify areas and just feel comforted to know what to look for and how to deal with
Our
it.
goal, forgive me for interrupting, our goal is to have what we're talking about today, suicide crisis syndrome, as a diagnostic category, both in the ICD-11 and in DSM-6. Because if that is the case, then it is taught to all professionals.
Exactly.
Then insurance companies pay for it. Then research on best medications is done. And then public is educated. And the response to what I'm describing to you would be like CPR, that people know, or saving a choking victim. It would be on that level.
And it will be in the public sector and with families and just everybody. Thank you. It's an amazing piece of work, I must say. Thank you so much.
Thank you. Much appreciated. Bye-bye.